We have almost, for now, 45
Okay.
as a start, and we have 150 registered.
Yeah. So, I mean, it's the weekend. People, you know, have a lot of things going on. So it's understandable. But if you want to introduce me or whoever will introduce
Yes,
me,
yes, I
then
will.
I can put my slides up whenever you tell me.
Okay. I'm waiting everyone to join. Still log in.
We're in the webinar now, right?
Yes, we are
So in the
here.
webinar, yeah, we have 54 participants so far.
I'm giving 2 minutes, so everyone ready.
Do you want me to share my slides now?
Okay.
Yeah, I think
Just to make sure things work in case we have a problem.
okay. So we see the display and we'll double check that everything is going fine.
Okay.
Okay, excellent. So we see the whole thing. Yeah.
Okay, great.
Awesome.
Perfect.
Yeah, and it's running fine.
Still people joining. Okay.
So now we can see the first slide,
Yes.
clinical implementation. That's the one we see there.
Can you see my slides?
Yes, we can
Okay,
see it.
perfect. Perfect.
So we will record. Record is on.
I don't hear you very well. Hopefully you can hear me.
We can hear you
we hear
very
you
well.
Okay,
clearly.
okay.
Yes, I want to make sure that recording is on. Yes, it's on. Yes, let's start. Good evening, everyone. My name is Merit Al-Madawi. I'm a breast imaging consultant, and I'm serving now as the president of the Egyptian Society of Breast Imaging. It's my pleasure to moderate today's webinar and welcome everyone on behalf of our society. Our society, a quick note before we start, it started the past few years, and at start it was driven by simple visions that we want to make breast imaging education and, of course, appropriate practice accessible to radiologists across all over Egypt. And then building meaningful connection with experts from around the globe. And this has started as a local initiative, and it's grown really to truly international educational platform, connecting colleagues, experts from across all the continents and bringing the advances, discussions, expertise in the breast imaging directly to our region. The Egyptian Society of Breast Imaging is the official society in Egypt presenting the breast imager and breast imaging specialty as a subsidiary from the main Society of Radiologists in Egypt, the Egyptian Society of Radiology and Nuclear Medicine. Tonight, it's an example of that visions, simple visions become a great reality. This webinar, this series, it's called the Breast Imager Without Border. It's becoming a flag activity track now in our society. And it's not limited by any border, as you see. We have built bridges and we have invited and host many speakers from all around the Arabic region and from other region. Today is the first time to go west, like the previous webinar we had from Kuwait, Saudi Arabia, Emirates, and many from the west to Egypt, east to Egypt. Today it's our first faculty guest here from the west to Egypt. Today has become a program. We include multiple other tracks in our society that target, for example, the rising stars, the young radiologists, the residents, And also this track that you see now, it's bringing together all the experts from all over the world. I have the privilege to welcome, and I'm honored, pleasure to introduce Dr. Stamatia Destounis. And it's a great honor, really, because Dr. Destounis, she is international distinguished expert in the breast imaging field. She served now as the chair of the American College of Radiology Commission for Breast Imaging and chair of ACR BI-RADS 6th edition Atlas Mammography Committee and chair of the RCMA Breast Planning Committee. She also served as the board of chancellor of the American College of Radiology, ACR, and hold multiple editorial and leadership position that's big to mention it all here. She's author for over 150 peer-reviewed publications, contribute to many chapters in many textbooks, and delivered thousands of lectures international all over the world. I see her commitment to education. It's very inspiring, and she has been named RCMA Honored Educator for 2026. Congratulations. And she's a true privilege to welcome her in the Egyptian Society of Breast Imaging. Thank you so much for sharing your expertise today with our community in Egypt and in the Arabic region. Something get my attention before I begin. I was seeing our social media pages when I noticed that EGSBI today, she has around 500 members registered and 8K followers from all across the social media platform. So especially in Facebook, this was like 8K. And I found that we are getting closer to the number of followers for the SBI. So I was so happy, and I want to tell you that prepare, because EGSBI is coming. For our SBI colleagues, we are coming slowly, but we are steady, and we are very motivated and dedicated to spread education everywhere. All my dear professors and colleagues, please join us in warming welcoming to Dr. Stamatia Destounis.
Thank you so very much for that wonderful introduction. I'm very happy to be here. Thank you for the kind invitation. And we're going to spend a little bit of time this evening for you and afternoon for me discussing a few topics. One is tomosynthesis and clinical implementation, and we're going to start there. I'm hopeful that I'll be able to move my slides. There we go. I was asked if I was going to give you any questions, so I'm just giving you something to think about. Very easy questions. We're going to talk about these topics. You don't have to come up with an answer now. We're going to discuss at the end. So one is a multiple choice question. What is considered the biggest benefit of digital breast tomosynthesis? A, reduction in recall rate. B, increase in detection of ductal carcinoma in situ. C, increase in detection of invasive cancer. D, all of the above. So think about what is the biggest benefit. What do the studies tell us? And then a true-false question that we'll discuss at the end. The second question for this topic, the biggest benefit for digital breast tomosynthesis is in fatty breast tissue, true or false? So we'll get back to that in a little bit of time. So let's talk about where we are with digital breast tomosynthesis in the US today, and whether we are how are we utilizing digital breast tomosynthesis? Well, we're finding out that the MQSA, which is what drives pretty much everything we do, we're very much regulated and governed by the federal government, the FDA, and we get our MQSA data and information. So the scoreboard has been up for tomosynthesis since it's been around now for a while, so since June 2016. So what I wanted to show you is the difference between June 2016 to June 2026. So overall, the certified facilities in the United States has increased by a small amount from 8,740 to 9,099. So we don't have that many more facilities. The number of accredited units within those facilities, though, has increased quite a bit in that 10-year period, from 16,000 something to 27,551. If you look at how many facilities are certified with full field digital, that's pretty flat, from 8,500 to about 9,000. And accredited overall units have increased by approximately 1,500, from 12,508 to 14,121. But the biggest change here is the certified facilities with digital breast tomosynthesis. 10 years ago, we were at 2,444, and now we're at 8,605 facilities. So most of the certified facilities in the country have at least one tomosynthesis unit. And how many accredited tomosynthesis units do we have in those facilities? We went from 3,362 to 13,430. So really a big difference for us in the United States with implementation and really people taking on tomosynthesis in their practice. Some of the early tomosynthesis screening studies, and this is a nice review article by Regina Hooley published in AJR some years ago, really go through, international multi-center studies done in Europe by Seattle, Friedwald multi-center, predominantly done here in the United States. So we have single centers, private centers, academic centers. Rose was a single center, private. Sharp, also single center. But overall, when you look at the recall rate between digital mammography and then the recall rate for tomosynthesis, we're seeing a drop in the recall rate overall. So a reduction in recall rate. And overall, when you look at cancer detection rate, the cancers per 1,000 and the absolute cancer detection went up by migrating to tomosynthesis. So that was the general consensus. We're finding some more cancers, maybe one more per 1,000, but we're really reducing our recall rate. And the Friedwald study showed that, and every other study, whether single center or multi-center. Zuckerman published in the Journal of ACR in 2020, it was an SBI member survey. And they really looked at how are we using tomosynthesis? Are we using the synthetic 2D mammogram, or are we doing combination with digital mammography and the tomo? So 40% at that point, and this was published in 2020, 40% of the SBI members said they were trying to do something both, using some synthetic mammography, but also using the 2D digital mammography with tomo. 52% reported that they were using the synthetic mammogram for their full field digital representation without doing a combination mode 2 exposures for their screening patients. And overall, at that point, the synthetic mammography satisfaction for those members was 3.4 out of 5. And you can see that we're looking at different types of practices, whether academic, private, or hybrid. And most of the practices, that's what I have circled in yellow, most of the practices had tomosynthesis capability. They really concentrated on this study in really asking about combination mode imaging and double exposure versus a synthetic mammogram and tomo. So most of us really like that reduction in dose and also the conspicuity increase that we may get for lesions by having the synthetic 2D. So, but the disadvantage for most of the radiologists that were using synthetic mammography was that their feeling was they were not seeing calcifications as well, and they could not characterize them as well. But overall, the studies have shown, the early ones and then later on too, that we are seeing a significant reduction in recall rate. So it reduces the number of false positive screening examinations that we perform. And it does improve cancer detection. It does increase invasive cancer detection a little bit without change in the ductal carcinoma in situ detection. Finding cancers are invasive earlier. It gives us a lot of opportunity to perform minimal treatment and offer minimal treatment to our patients. And tomosynthesis really improves the conspicuity of the lesion, the localization of the lesion, and also the margins of a mass or whatever it is we're looking at. So most of the studies, although there may not be complete agreement, there's potential for reduction in interval cancer rate, which is the cancers in between screening cycles. And it is a benefit for overall all patient populations, whether the young, middle-aged, or the elderly patients, and especially the younger patients and those with a more dense pattern. So when you're ready to incorporate tomosynthesis into your practice, you have to consider some things. First of all, whatever vendor you use, it's going to have to be a big budget item for you for the year, whether you're in academic practice and your department only has so much money to spend, or in private practice. So the budget is important. The room has to be larger because that arc has to move. It's not a stationary digital unit, so you need more space. And whether you transition one unit at a time and slowly as you can afford, or you only have 2 units and you're going to go ahead and change and do a full transition, you have to have some downtime in order for the new units to come in order for your technologists and your radiologists to become familiar with the technology. So there's some downtime. You have to reduce your schedule, cancel patients. So those are all things to consider. There's also the dose consideration, especially early on when everybody was doing combination mode and double exposing the patient, and we all had a learning curve. It took us longer to interpret these images, so you have to allow for that in your day. You are not able to read as fast as you were before. And then you need IT support. This is very technical in many ways. And if your PACS does not communicate with your radiology information system, if your dictation system does not communicate, all of these things will make this transition a bigger challenge for you. So you do need to have somebody that can help you with that transition. So you need people that are experts at this. When we look at the dose, as you can see here, when you're doing just the 2D, this is what the effective dose is in millisieverts. You add the tomosynthesis to it, you're doubling it. However, the average annual background dose in the United States, you can see there, it's at 3. And if you live in Colorado, beautiful state, but you're going to get even more of a dose there. Background dose is at 4. So looking at what MQSA allows for radiation dose is still 3 milligray. So with the full field digital, you get 1.2. With the digital breast tomosynthesis, 1.45. So the combined dose is still less than the 3 milligray that MQSA and the FDA allows us. But you have to think that when you're doing tomosynthesis in combination, you're giving more radiation to the patient. Very early on, we were, careful about the radiation. We were also interested in the different patients that we had. And so we looked at 100 cases at my facility, Elizabeth Wendy Breast Care, and we published this looking at the difference in radiation dose between tomosynthesis and conventional mammography across all breast densities. And really we found that our fatty breasts, our BI-RADS 1 or 2, A or B, received a higher average mean glandular doses on tomosynthesis. And in fact, our most fatty breasts experienced the greatest difference. So there was as much as a 30% higher dose with tomosynthesis for our fatty breast tissue. And this was kind of what we found in our 100 cases. So the red is 3D or tomo, the blue is full field digital. So when you look at all breast densities, it's very similar between full field digital and tomosynthesis, but for A and B or 1 and 2, as you see there is a difference. The dose is higher and then gets closer for the heterogeneously dense and extremely dense categories. We also all had to do training. So we needed an initial 8-hour training course with test cases. Now you can get that from most of the vendors or even the CME companies that you may have a relationship with. And remember, your reading time slows down, especially if you're a high volume site like mine. It really did make a difference for us transitioning. We had to allow ourselves time to really read the tomosynthesis cases, the scrolling was consuming, and there was a lot of differences in how lesions appeared. When you're first involved with this, it takes some time to get more familiar with it. Our technologists had to document training through application specialists or a designated staff member that was a super user. And there was a learning curve. This is a lot more computer-like than the traditional units you may have been using with full field digital. So the reading takes 2 to 3 times longer than when you're reading digital mammography. Initially, you have to give yourself time. If you're going really fast, you're going to be missing things. So 5 to 10 minutes initially, and with experience, you can get it down to 2 minutes. I have here many articles, as you can see, like Wallace said that it took him over 2 minutes to read Tomo. It was 67 seconds with full field digital. Dang said 168 seconds for tomosynthesis, while full field digital was 114. You see quite a bit of variability between some of the European sites, 33 seconds for full field digital, 77 seconds for tomosynthesis. So some people read quite fast too. Does having experience reading digital mammography affect your reader performance with tomosynthesis? This article by Tucker had 24 readers. There were 19 radiologists. They also used some advanced practitioner radiographers. This is in Europe. And so they had 3 of them and 2 breast clinicians. And this is from the TAMI trial. And really the specificity improved for tomosynthesis for all readers. And the sensitivity actually improved for most of them, about 80% got better. And really, it was a significant difference and significantly higher for those that had less than 10 years of experience and those that had read less than 80,000 mammograms. So the younger radiologists, did better. They were more willing to accept the findings they saw on tomosynthesis likely, less so for us. Some of us have been doing this a very long time, and, the learning curve is a little different for us, and it takes a lot to make us change our mind about something. So initially, the bandwidth and the network storage was a big issue for us in order to meet the demand of storing all the tomosynthesis units because the files were so large. Of course, breast size made a difference. The planes that you use to, accumulate the images. So now with the slabs, that you're able to do slabs, that of course that really reduces the exam size. And some facilities did not archive everything. Now with data compression, it reduces the overall size, and we're all, are not suffering as much with our archival needs because archiving was very expensive early on with tomosynthesis, but all the costs of this has all come down. So who benefits from digital breast tomosynthesis imaging? What's the right patient population? Well, looking at an article by Sharp and looking at demographics, they found that, the recall rate was lower for tomosynthesis than digital mammography for all groups, regardless of their breast density, but was most significant for the heterogeneously dense and extremely dense population. And also when they looked at patient age, the reduction with tomosynthesis, it was great for all groups, but most significant for the 40 to 49 age group and the 60 to 69 age group. And even, the baseline population, that's where we're likely to recall the most because we don't have anything to compare these patients to. The recall rate significantly reduced by, but from 19.6 to 9.88%. That's significant changes that happen looking at breast density and also ages of patients and even baseline mammograms. So Dr. Rose actually looked at their own patients, and they also were able to reduce their recall rate overall. However, their biopsy rate increased and their cancer detection rate increased. They felt that was important because they were recalling patients appropriately and biopsying them. So their biopsy rate went up because they were finding more cancers. And overall, in patients with dense breast tissue, the recall rate decreased for them while their biopsy rate increased. This is a patient that came in, and she came in for a baseline. She's 49. Now, we do recommend starting at age 40 in the United States, but some referring physicians and some patients obviously will come in when they want. So she was 49. This was a baseline. She has, you may say, extremely dense glandular tissue or heterogeneously dense glandular tissue. And I want to show you this one specific area. This is showing you kind of blow-ups of the slices on the MLO view is on the left and the craniocaudal view on the right. And so those slices are showing us architectural distortion. And so let me see if I can show you this, and hopefully you can see it. So here's architectural distortion that we're seeing both on the MLO view and the craniocaudal view. And this patient went to ultrasound, and in the right superior breast, we found this area of architectural distortion, irregular mass, that you can see both in trans and long. And this became very easy task to biopsy this under ultrasound. We knew exactly where to go because we could see it both on the MLO slices and the CC slices. But even when you only see it on one of the two, you have a better idea at lesion localization when you're doing tomosynthesis. So this was biopsied, and this was invasive lobular carcinoma on ultrasound. Now, this is a 46-year-old, and she comes in for a screening. She has extremely dense glandular tissue. We're all looking at that metallic artifact, right? That really can cause us some kind of tunnel vision sometimes because we're focusing on the left. This patient has extremely dense breast tissue, like I said, and I want you to focus in the other breast because what I'm showing you is that this is the synthetic mammogram, the synthetic 2D mammogram in this patient, because I don't do combination. But we're looking at this area. And of course, we scroll through on our workstation and look at all the tomo slices. But we have slabs also, so we can do slabs. So this is an area of architectural distortion. You're seeing right up superiorly near the pectoralis muscle. And in this patient, you can see that you have lines coming out of this area. So this is very suspicious. So we're able to go to ultrasound. We saw it well, because of its location, it's so far back. You know, you can do additional exaggerated craniocaudal views and additional views to see it. But if you have a good idea by scrolling through where it is, you can go straight to ultrasound. And in the right lateral breast, we're able to identify this area. And this was also invasive lobular carcinoma. So this is an article by Rafferty in JAMA some years ago. And she also looked at tomosynthesis in dense breasts. And what they found was that looked at the cancer detection rate and recall rate with and without tomosynthesis. And they found that with tomosynthesis, the recall rate went down and the cancer detection rate for the non-dense population went up, but also for the dense population, the invasive cancer detection rate also went up. The improvements were greatest for the B and C categories in this article: scattered fibroglandular density and also heterogeneously dense. So what is the optimal screening regimen for patients that have dense breast tissue is currently, under a lot of investigation. Ultrasound has been very accessible, and we've had the breast density laws in the United States for many years, New York since 2013. So we're doing a lot of ultrasound. And some people were like, well, tomosynthesis can take that over and we don't have to do ultrasound anymore. So when we look at, incremental cancer detection rate, we are seeing that, yes, with tomosynthesis, in a lot of these retrospective studies, this was published in the British Journal of Cancer 2022 by Lee, and they really looked at the differences by breast density for detection of cancer for digital breast tomosynthesis versus digital mammography. And they did a systematic meta-analysis. And this very nice article showed that the cancer detection rate was actually greater in the high density population. There was a substantial proportion of additional cancers that were also detected in the low density screenings. And this is a TOSIMA trial sub-analysis. And this was published by Dr. Weigel and her co-authors. And what they found was, again, another comparison of breast density and breast cancer screening. They found that with tomosynthesis and using synthetic mammography, not the combination, but the synthetic, they found 2.7 more invasive cancers per 1,000 women with dense breast category C or D. And really the difference was the highest for invasive cancer detection in women with had extremely dense breasts. So category D. And this was tomosynthesis with synthetic mammography. I'm going to show you another example here. This is a 51-year-old, and she has dense breasts. So she presents to our facility, for evaluation. So she comes in for her mammogram, and you can see that she does have the heterogeneously dense pattern. And I want you to look at the left kind of central breast area in this dense pattern and see if I can move my mouse, which doesn't want to move.
I can annotate it. I can annotate it for you. Would you like me to annotate?
Yeah, it's not moving forward for some reason. Like, oh, there we go. I got. Oh, maybe you. Thank you. That's perfect. So you drew it. Thank you so much, Merit. So here we are on the CC and the MLO view. Oh, that's perfect. I love that. So we have this area of architectural distortion. So I'm really painting a picture here for everyone that with dense breasts and women that have heterogeneously dense pattern and extremely dense pattern, we're seeing these kind of subtle areas of architectural distortion. You can see this on both views. I love that. Okay, so now how do we erase that, Merit?
Yeah, I need to find now a way. Yeah, I found.
You got it? Perfect.
Yes.
All right, so here we are. Thank you for the help, though. So this is, we're looking at this area, and you can all see it. It's beautifully depicted in on this blow-up view here, the magnification view. You can see lines coming out of it. You have a central mass. So I think everybody can see that. So I have the tomo here. So let's see if this plays. And beautiful, it's playing. So hopefully you can all see it. I'm going back and forth, and you're able to do this on your workstation also. We're looking on the medial lateral oblique view, and we're looking at this left central area. So we're going out of it, and now I'm coming back into it so I can show you. You can see the architectural distortion very nicely. And let's look now at the other view. This was an invasive ductal carcinoma. And there it is. So everyone can do cine if they want. I like to control my mouse, whether I'm doing slabs or we are doing just labbing on our units now pretty exclusively. So, but you can change that if you want, and you're able to control on your workstation what you're looking at. So there it is. So this was an invasive ductal carcinoma, and you can see it on both views. So that's very helpful. You can go to ultrasound and do the biopsy under ultrasound. So when you're doing diagnostic imaging, what are the advantages of tomosynthesis? Well, I think it can replace the traditional diagnostic views in most cases. In fact, early on, there was a lot of work being done and published. Pepard was one of the articles that got published. Hakim was another one. They really looked at whether they needed to do the full field digital spot compression views for non-calcified findings and also for single view findings. They found that the 2-view tomosynthesis in most cases was sufficient, and that allowed for the number of additional diagnostic evaluation with full field digital to reduce, so the patients could go straight to ultrasound. Raghu also looked at tomosynthesis in the diagnostic mammography setting on the BI-RADS final assessment, and they found that they were able to reduce their BI-RADS 3 category by using tomosynthesis. So they had 17% more patients go to BI-RADS 1 or 2 with tomosynthesis, and so their BI-RADS 3 category was 17% less. So that's really important, you know. That's great that we don't have to call the patient back for 6-month intervals, and we can send them away with the BI-RADS 1 or 2. There was no significant change in the BI-RADS 4 or 5. That's good. We don't want those to change. But the PPV overall was greater with tomosynthesis. Now, this is a 36-year-old, and she has a family history of breast cancer. She comes in feeling a painful lump. And you can see the marker on the CC view and also on the bottom of the right MLO view. So we're looking at a young patient, 36. She has a family history of breast cancer, and we can see a mass on both views. And so this is a diagnostic patient, not a screening. So here's the slice. And I feel like on the craniocaudal and medial lateral oblique view, you can see the area very nicely. You're able to describe what this mass looks like. You can see the margins very well. Now, in the beginning of your travels or your learning curve with tomosynthesis, you may want to do your spot views, tomo views, whichever way that you do your workup of a palpable lesion, like in this case. But you can really go from the 2-view tomosynthesis straight to the next step, which is usually ultrasound. And this patient had this mixed solid and cystic mass in the right inferior medial breast at 5 o'clock. That was palpable, close to the skin surface, and we biopsied this, and this was invasive mucinous carcinoma in high-grade DCIS in this young patient. This is a 54-year-old. She comes in with pain and tenderness for 2 months. We do have lots of patients that come in with breast pain, as I'm sure you do also. She does not have an extremely dense background or even a heterogeneously dense background. I would say this is more scattered. But we're looking at this lady. She does have pain. She comes in with tenderness. And I want you to look at this one area in the right breast. And hopefully I'm able to show you this. So we're looking at centrally on the CC. There's a blow up. Perfect. So here we're looking at this one area. And I know this is a still image. And you may be like, I'm not so sure, but as you're scrolling back and forth very slowly, 1 millimeter slice at a time, you're seeing some distortion in that tissue on the craniocaudal view. You may be seeing it better on one view than the other, but if you look on the MLO view, you can see it also on the medial lateral oblique view. Just because it doesn't look exactly the same between the craniocaudal and medial lateral oblique view, you don't discount it. You still have to evaluate it. You still have to, look at both sets of images. So here we have the C view, which is a synthetic 2D on the most left, and then the tomo slice, where we see that architectural distortion the best. So hopefully you can see this. That's on the craniocaudal view. And we were able to biopsy this. We could not see this on ultrasound. We tried very hard to find it, but unfortunately, if it's scrolling, we could see it on the CC the best. We could see it on the MLO. So we did a biopsy stereotactically of this area, and you can see the marker in the correct region. So this was an invasive ductal carcinoma. So even if you don't see it on ultrasound, you think you're seeing something on 2 views or even predominantly on 1 view finding, if you cannot make it go away with your workup, even if you don't see it, with ultrasound, you have to persist and biopsy it. So tomosynthesis only findings. We're finding these subtle tomo-only cancers. You're going to find more of them. So you may have to reset your threshold of what you're passing and what you're calling back. You're also going to find more radial scars. That's definitely going to happen. Dr. Conan wrote a nice article on tomo-only cancers and also radial scars. So ultrasound is important, but you also have to have biopsy capability with tomosynthesis. If you don't, then you're going to have to do tomosynthesis guided preoperative localization for tomo-only or predominantly tomo-only findings. So how do we do a tomo biopsy? So if you find something only seen on tomo, if you don't have biopsy capability, then you go to ultrasound. You do additional imaging with your full field digital images. You do a stereo biopsy by looking at your landmarks. Or you recommend open surgical biopsy and you do a tomosynthesis guided localization. If you do have biopsy capability, then you go straight to your tomosynthesis guided biopsy. So tomosynthesis biopsy, Dr. Ariyaratnam published a very nice article about tomosynthesis detected sonographically occult lesions, and this was published in Clinical Imaging a few years ago. And so they had 38 lesions. They could not see them on 2D mammography. They could not see them on diagnostic targeted ultrasound, only saw on tomo. 16 were masses, 16 architectural distortions, 6 asymmetries, and they were able to biopsy all of these with vacuum. And the average procedure time was 15 minutes. You can get that down a lot more, especially if you're getting more and more proficient with biopsy. And they found that 57.9% of the cases were either high risk or cancer. 8 were cancers, 14 were high risk. And then they recommended excision on their high risk lesions. And 10 of the 14 went to surgery, and 2 out of those 10 that were surgically excised also were cancer. So their upgrade rate was 14%. So that's impressive numbers that when we have tomo-only findings, we still have to persist and keep going. We can't give up. This is a 53-year-old, and she came in for a screening mammogram. She does have some islands in the upper outer quadrants of, and right behind the nipple of more dense tissue. So if we're using 5th edition or version 2025 manual breast density characterization, we would upgrade this to heterogeneously dense. But I do know many radiologists still look at the whole breast and still would call this a B. So she comes in for a screening. We're seeing this area only on the craniocaudal view and only on the tomos we're scrolling through. This is the synthetic 2D mammogram I'm showing you. So here is the C view. We're seeing this area specifically, and here is the slice, the tomosynthesis slice on the right, and you have very subtle architectural distortion here. So here's my laser pointer. I discovered it. This is on the slice, and here's a synthetic 2D mammogram. Not as easy to see on the synthetic 2D mammogram, but it's definitely there as you're scrolling through. And that's the area we're looking at. So we have the capability to do biopsy at my facility. So you can see, and I'm sorry now it's not, let me see if I can go back. I was hoping to let me play the Tomo Scout, but it's not letting me play. So, but if I was able to play it, I would show you that this area pops up right here on the Scout. It's not as easy to see. The patient is laying on their stomach or compressed a little differently, so you may not get exactly the same look. Let me see if I can take the laser pointer away. There we go. I had to take the laser pointer away, and now I can show you. So here we are. I'm hoping you could see it. Merit, hopefully you can see it and you can respond, since I can't ask everybody.
Yeah.
Do you guys see this little architectural distortion popping in? All right, beautiful. Thank you so much for the thumbs up. Thank you. Perfect. Okay, so then you do your pre-fire images. You've numbed the patient. Once you put lidocaine in, then you're going on faith, because you're not going to see that area anymore. It's a one view finding. You do your pre-fire, and then you have to keep going at this point. Because once you have the lidocaine in there and your biopsy needle in there, you're just looking at landmarks now. You're not going to be able to see a subtle 5 millimeter area of architectural distortion. So, but that's your pre-fire. And then I have everything side by side for you guys so you can see it all. Here's my laser pointer. This is what started our travel. This is our Scout slice with the architectural distortion. Here's our pre-fire, and here is our clip and our post-biopsy changes with the void there where we were able to get the area. So that's what started this, and this was a small grade 1 invasive ductal carcinoma, seen on only one view, not seen on ultrasound. and were able to successfully biopsy with tomo. So where we stand with tomo as a standard of care, lots of articles out there. This is an article by Dr. Christoph Lee. They looked at the performance benchmarks for screening digital breast tomosynthesis. We have a lot of numbers that we get from the Breast Cancer Surveillance Consortium. So over 2 million exams. Many of the metrics that they looked at were improved with tomosynthesis. The abnormal interpretation rate was lower, so they recalled less people. The cancer detection rate was higher, PPV was higher, and more invasive cancers. So that's what we want to see. This other study is by Dr. Conan, and they looked at, it was multi-site with digital breast tomosynthesis and digital mammography. They had over 2.5 million screening mammograms, and they compared tomo and digital mammography. They found it was lower recall rate, higher positive predictive value of the recall, and higher cancer detection rate. And the biopsy rate was effectively higher with tomosynthesis, but they were also finding more cancers. So as we're looking across all these different articles, Dr. Sprague has another article with the Breast Cancer Surveillance Consortium data, and they looked at successive screening rounds. And this was kind of interesting because the absolute recall rates were lower, even as you looked at successive screening rounds on patients, not just the first time, not just the second time, but over time, and higher cancer detection rate on the third screening round. But they did not see any difference in interval cancers or advanced cancers. So what are the benefits? What are we seeing with types of cancers detected? Well, a new technology has to show that it's finding more invasive cancers than in situ cancers. So far, the studies support that. The preferentially tomosynthesis does find more invasive cancers, and the data support that they're smaller, lower histologic rate, less likely to be node positive. Can we really talk about mortality reduction? We don't have enough data. We have suggested data with interval cancer rates to look whether tomosynthesis impacts screening, but the decreased rate with tomo screening of recall rates and also of reduction in some of the studies of interval cancer rates, that suggests improved cancer benefit. We want to find cancers early, so that's another thing. We're finding smaller invasive cancers. So what about the interval cancer rates? Well, when you look at the studies, and I have many different studies here, and you're comparing tomosynthesis to digital mammography, you can see most of these say not significant. Some say was significant, like the study by Duran, study by Conan, Ball, but perhaps there may be a decrease in the interval cancer rate when we're using tomo because these may be faster growing cancers, possibly overall that will contribute to lower breast cancer mortality. So what are we seeing in this article? Well, this randomized controlled trial, again, comparing digital mammography to tomosynthesis by Dr. Armaroli, and they published this in the International Journal of Cancer in 2022. They had less interval cancers in the tomosynthesis arm of the study, although it wasn't statistically significant. But they had statistically significant reduction in more advanced cancers by using tomosynthesis. So really, they're still analyzing data, so they're doing a third screening episode of this trial. But we're getting some information here that's helpful, or at least encouraging. Less advanced cancers, maybe less interval cancers, although maybe not statistically significant. What about interval cancers in dense breast? We know that we're missing cancers in women with dense breast. So this study by Noguchi actually really looked at this. They looked at the different breast densities. And what they found was that by using tomosynthesis, they found that they were impacting the dense breasted women more. So I think that's encouraging data, that we are reducing interval cancers, or we are reducing the interval cancer rate in women with dense breasts at the same level as women with fatty breasts. So this article is by Dang, and I like this article, and I included it because, again, it's the total cancers, 2D versus tomo, more cancers, DCIS, not much more invasive cancers, more minimal cancers, more non-minimal cancers. So everything was more with tomosynthesis. But they also looked at, along with the overall size, they found that by using tomosynthesis, they found smaller cancers, they found more well-differentiated cancers, more ER-positive cancers, and more cancers that were node negative. So all good characteristics. So overall, more screening cancers were found for tomosynthesis, irrespective really of the tumor type. And so they found more cancers in invasive, in situ, minimal, and non-minimal cancers. But among the invasive cancers, it was statistically significant, node negative, well-differentiated ER-positive tumors. So lots of articles have really looked at this carefully, the difference between invasive and advanced cancers and these two technologies, full field digital versus tomo. 𝐁𝐫𝐞𝐬𝐢 actually had a cohort of women that were over 500,000, 40 to 79 years old, over 1 million screening mammograms, and over 375,000 tomosynthesis exams. And this is another BCSC study. So although the incremental cancer detection rate was not significantly different, they found that the advanced cancer rate was significantly lower by using tomosynthesis for the 3.6% of women that had extremely dense breasts and were at high risk for breast cancer. So really, this is pretty meaningful. These are women that are high risk. These are women with dense breasts, and the advanced cancer rate was lower by going to tomosynthesis. So overall, in summary, by going into the clinical implementation of tomosynthesis, switching from full field digital, it's the better mammogram. It reduces recall rate. It increases cancer detection rate. Even if all the authors don't agree how much, it does increase invasive cancer detection rate. And it's useful for diagnostic and for screening. And the benefits are sustainable over time. As we saw, multiple screening cycles, we're still finding cancers, and the recall rate is still less. So overall, it improves our interpretive performance and likely will replace conventional digital mammography in clinical practice. So let's go back to those questions now. What is considered the biggest benefit of tomosynthesis? And I said a lot about this. Is a reduction in recall rate? B, increase in detection of DCIS. C, increase in detection of invasive cancer. D, all of the above. But remember, I said, what is the biggest benefit? And although it does increase invasive cancers, it does not increase overall the detection of DCIS, so it cannot be all of the above. The biggest benefit is very good, very nice, reduction in recall rate. So very nice. So that was easy, right? Easy for you guys. And then the second was true or false. The biggest benefit for tomosynthesis is in fatty breast tissue. So no, the biggest benefit for tomosynthesis is it's good in all patterns, but the biggest benefit is really for the dense breasted patients and the young patients. So, okay, and I want to thank you. That's the end of the first talk. And my email, if you guys want to screen capture it, send me an email if you have a question later. I'll be glad to answer the questions. And I'll be glad to answer questions as they come in now. So I'm going to stop sharing so I can go through questions. Did you guys stay awake?
Yeah. Oh, it's very interesting. It's not only informative and evidence-based, but it also highly practical. Immediately we can applicate it in our daily practice. I think everyone here, you receive, as you see, you receive a lot of hearts and
yes, I see that. Very nice. Thank you so much. I love the way you circled that to help me. Thank you. I love it. Then I'm like, how do we get rid of it? That was perfect. Yeah, I was like, oh, where's my pointer? I was trying to find my pointer the whole time. I found it eventually. It took me a while. All right, so
I'm introducing our panelists today. Can I introduce my panelists today? We have a professor, our dear professor, Dr. Rasha Kamal, professor of radiology in Cairo University and head of radiology, breast imaging radiology in the Bahia Foundation for Breast Cancer Treatment and Screening. We have Dr. Heba Hussein. Dr. Heba also is a Cairo University graduate and staff before she had a long journey over many continents, and finally she is now an assistant professor of radiology in Toronto University. I'm also welcome Dr. Amal Higazi. She's also one of the EGSBI board members. She's very active educator. She is from Alexandria, and she has a lady scan woman imaging center, one of the eminent center in Alexandria. I also noticed that among the audience, Dr. Layla Ashar, I think you familiar with this name as she was the moderator of your last webinar with the
That's right.
Radiological Society of Saudi Arabia. Also, I want to welcome her. And you have you received a message from Dr. Hanan Gouefa.
Oh, yes. Yes, that's my friend.
Yes, she's sending a very warm message. She said that she want to attend and she want to be here and warm welcoming you in Egypt and EGSBI. And she also mentioned your nickname. Can I say it?
Tula. Tula.
Yes.
Everybody calls me Tula.
Yeah. Hi, Tula. It's I'm very happy you are here, and I wish to be there to welcome you. Warm welcome in the EGSBI, Dr. Hanan, but she has a very bad internet in the.
Oh, yes, I understand.
Yeah, she's in the Sahel. It's Alexandria's extension along the Mediterranean. It's a beautiful place, but no internet or bad internet.
That's
So
fantastic.
everyone, yeah. So I will give the panelists to
ask the
discuss with
question.
you this very
Can you hear me?
important.
Can you hear me quite well? Because I
Yes,
don't
we have you, Dr. Ahab.
Okay, so some interesting questions. First of all, thanks for this amazing lecture. And there is some interest in the slabs. So all the questions are along the same lines. So explain the slabs. Do you only read the slabs? And I think the question means the 3D and not the 2D.
Oh,
And then another question that was worried, I think, about the dosage, which says, do we have to follow the 10-day rule, which, historically we used to image the patients in the first 10 days of the cycle. I have this question that not necessarily, because they have to get the test and it rule out pregnancy, but that's the question. And along the same lines of the slabs, I have a question. So, on the last SBI, there was one of the vendors, I'm not naming the name, but they had this smart slice, which reconstructs the conventional 1 millimeters to 6 millimeters with a 3 millimeter overlap. So I don't...
With overlap.
Yeah, so I wonder if you have any experience with that. So
yeah,
slabs.
so, okay. So let's talk about everything. If you cannot, Tomo's great, but you cannot, you have to look at your 2D equivalent. So if you're doing combination, you have to look at your digital, full field digital for the lay of the land to get, what you're comfortable, what your priors comparison. So you compare, you're looking for calcifications, you're looking for whatever changes, skin thickening. You have to look at whatever your 2D equivalent is. You cannot just read the synthetic 2D. You cannot just read the Tomo. You got to read both of them because you're getting information from both. So if you're doing synthetic 2D mammography, you're going to put the synthetic 2D mammogram up and you're going to look at your prior synthetic mammogram or full field digital. So you do a comparison there and then you read your tomosynthesis. We were reading 1 millimeter slices right on our workstation. Sometimes for calcifications, you cannot tell if you have a small grouping of calcifications if you're doing 1 millimeter slices. Sometimes you have to make it a little thicker, 3 or 4 or 5 millimeter slabs, so you get that, oh yeah, there is a grouping of calcifications there. If you're only seeing one calcification, you're not going to understand it's a grouping. So hopefully your synthetic 2D or your full field digital mammogram is pointed those calcifications, but as you're scrolling through, you can make your slabs, your slices more, especially for calcium. Now, there's more than one vendor that's doing slabs now, Hiba. So, but yes, so they have 6 millimeter, and they have, you know, with the intercepting 3 millimeters, you know, and yeah, we are using that. We are using them. And in the beginning, I was very concerned that I was missing things. So I kept going back to the acquisition workstation to look at, because I was, you know, because it's saved there. So you can send them over to your PACS if you want. So in the beginning, we were sending everything to PACS. So we were looking at a million things. We were looking at the synthetic, the 1 millimeter slices, and then the slabs too. Then I said, stop sending it to our PACS. And then if I had a question and I wasn't sure, I went to the acquisition unit and I looked at it there. But we're used to it now. In the beginning, we were a little nervous that we're missing things. But I can't, we are not missing anything. So I like them. But I think it takes a while. It's a big learning curve to get comfortable,
Another technical question from Dr. Mohammed Yahya. He's asking, which angle do you prefer in tomosynthesis, the wide or the narrow angle?
So I'm only a narrow angle user. So, you know, they came in first, you know, they were FDA approved. I did research with them. Then we started our clinical practice with them. So I think there's some benefits to having the wide angle. I've seen some really wonderful cases, you know, at conferences, at SBI, at RSNA, when I go look at it. But I'm familiar with the narrow angle more so because that's what I've been using since 2011.
Right. Another follow-up question. So sometimes when you have those images for consultation, and sometimes the tomo images would not be displayed because of difference in technology, like different in systems, and you cannot actually view the tomo images. You repeat the tomo? Would you repeat the tomo at your institution?
So, you know, especially in the beginning, we were getting discs. You know, people were sending all their patients for a second opinion or a biopsy with discs, and they were nothing was compatible with anything because it was all proprietary. So we could not view other users, and so if I couldn't find the finding, I couldn't biopsy it. So then you have to repeat it. Yes, you have to do the right thing for the patient. So of course, we don't want to do too much X-ray, too much radiation, but in the end, the patient's coming to us to solve their problem. So we have to solve their problem. We can't tell the patient, oh, I can't view it, so I can't help you. So we have, you have to do it. Yes, we have to do it because we have to give them the answer. That's our job. So that's what we have to biopsy it if there is a finding and tell them what's going on, or tell them it's overlap and it's nothing and there's nothing to worry about.
Have you stopped doing spot 2D views altogether now with the
Yeah, we don't do spot 2D views. In some cases, when I'm on the fence of a one view finding, I can't even believe it's real, I will do spot tomo views in the one view that I see it in, because if I see something on both views, no, but if I only see it on the one view and I'm not convinced, then I'll do a spot tomo. Understanding though that sometimes architectural distortion that's just starting, it hasn't really caused enough desmoplastic reaction, and sometimes when you spot over it, you kind of lose it. You know, so we have to be careful not to ignore something, because, you know, on the spot tomo view, sometimes we make it harder to see. Yes. So I go to ultrasound a lot. If I'm on the fence, you know, I look through the area, I scrolled up and down where I see this asymmetry, so I kind of have an idea where it is. I look with ultrasound, and I biopsy things off one view frequently with tomo. Leila has her hand up. I'm sorry.
Yes, Dr. Hiba, Dr. Leila Al-Ashkar, I think.
Yes, yes, thank you so much.
Yes,
great lecture. I appreciate it. I have a question. So you do not read off the T2D, you read off the C view, the synthetic view, correct? For
Right. So
screening
we don't do 2D anymore. So
anymore.
we do
Okay.
tomo and we reconstruct the synthetic 2D mammogram and we
Okay.
read that
Great.
along
And then
with the tomosynthesis slices.
the slices, because there are two different types of slices. There are the slabs,
Right.
and that's the confusing part, the slabs and the planes. So the slabs are like thicker slices, and the
Right.
planes are thinner slices, correct?
Right.
So you
Correct.
only read and you only ask them to send you the slabs, which are the thicker slices, and you don't ask them to send you the planes unless you have a question.
That's
Is that
right.
how I'm-
Exactly.
Okay, perfect.
Exactly, Leila.
Perfect.
Yes,
Yeah,
exactly.
and it saves a lot of storage as well.
Yeah, so it
Great.
saves a lot of storage. And you know, the thing is, in the beginning when we started it, we were nervous. So we did, you know, we sent everything. It took, so that caused like network issues, you know, the bandwidth was, you know, we kept having to buy more bandwidth because we, you know, all of the stuff that happens. But we've gotten more confident now in what we're looking at. And we are finding that we don't have a question like we did before, which we were questioning everything before.
So you think the slabs are sufficient enough?
Yes.
Okay.
That's right. And the studies have shown this. The studies have shown that the slabs are not inferior. Yes.
Okay, perfect. Thank you so much.
So the learning
I
curve,
think they are much
the
better in calcifications. So you can overcome the drawback of tomosynthesis with the slabs. Yes.
Yes, exactly. You're right. You're right, Rasha. So right. The slabs really help with calcifications.
Yes.
They do.
So the learning curve starts with combo first, and then when we are very confident, we start to eliminate the 2D and go with the synthetic views. Then synthetic views at start we can do the planes, then we go with the slab gradually.
Okay.
This is the pathway to be confident, right?
Right. Right. So the way I read it is I do the comparison of synthetic 2D to synthetic 2D from prior years, because I've now multiple years of different versions of synthetic 2D. And then I go into my tomo slices and I read each one. And then if I have a question on the tomo slices and I'm not sure that the synthetic mammogram is helping, I pull up my last year's tomo and I start looking at that and look at that area carefully.
And when you do spot compression, you do spot with tomo.
With tomo only, exactly.
Okay. And I noticed when you're doing the biopsy, stereo biopsy, I'm doing like a scout with the tomo because it's like very good to adjust the target. Then when I do the pre-fire, I do pair stereo.
Oh, you do pairs. Yeah.
To avoid these artifacts from the needle.
Yeah, it's a leap of faith at that point, you know, right? Once you got that needle in, you put the lidocaine in, like now you got to go. So, but yeah, I don't do the stereo, but that's reasonable. You can do your stereo.
Like the combination of both, it's okay.
Yeah, that's fine. It's whatever makes you feel, okay, I'm in the spot.
I want to see the target,
I'm in that right spot. We're putting the patient through a biopsy. We want to make sure we're doing it right. So whatever it takes, looking at the 1 millimeter slices, looking at slabs, do both. And if that stereo pair is what you need, go ahead and do it.
Okay. Yeah.
Good. I think we have one question again about the slabs. What thickness slabs do you use, and is it vendor specific?
So I couldn't hear you well. I don't know if Merrick could hear you.
What thickness the slabs? What thickness of the slabs you use?
Yeah. So with the vendor we use, we're using the 6 millimeter.
I think, Heba, we can stop here with the questions to give rest between the two lectures.
Yes. We're off to the break. So you can have some coffee and be back to our second interesting.
Okay, so what time would you guys?
Whatever you like, Dr. Whatever you like.
So I think it's 3:10. Well, so it's 10:10 for you guys.
Yes.
It's late.
It's
late for you. So
yes.
do you need a coffee break? Do you need to go to the ladies' room? Do you need a break? If you don't, we'll just keep going.
Okay, whatever. Yes, if it's convenient for you, we are okay.
It's fine for me. I'm good.
Okay. Yes, let's.
Listen, I gave a talk to a group of technologists, and it was me. And so it was kind of, it was just me. So it was kind of interesting. Like I gave after 7 hours, my voice was gone. So, it was kind of funny. I was like, oh, I better stop talking. All right, here we go.
Yeah. This is why the break, basically we are worried that you want the break.
No, I'm good. It's fine. This is just a few talks. We're all good. So if you're okay, and if you guys have to run to get something to drink, go for it. That's fine too. But the second talk is on MRI screening for patients at high risk. And now that I found the pointer, hopefully this will go fast. So I have a few questions. You're just going to think about them, and we're going to talk about them at the end. True or false, is MRI recommended by the American College of Radiology as a supplemental screening tool over ultrasound for patients with dense breast tissue? And it's true or false, or yes or no, okay? And then the second question is a multiple choice. What is the best screening combination for patients at high risk according to some of the studies that have been published in the literature? Is it FFDM and ultrasound? B, tomosynthesis and ultrasound? C, MBI and full field digital mammography? D, MRI and full field digital mammography? Okay, so high risk patients, what's the best screening combination, most accurate, most sensitive, according to some of the studies for high risk patients? All right. So let's talk about a little bit of risk factors and background. There are breast cancer risk factors that we cannot change. Being born a female, aging, getting older, inheriting certain gene changes, having a family history of breast cancer, having a personal history of breast cancer, and we cannot change our race and ethnicity. And we do know that some races and ethnic backgrounds are more at risk. So when we look at the pie on the right, most of the patients present without knowing they have any risk factors, 60 to 70%. And then some of the patients, 30 to 40, will have some known risk factors, whether it's genetics, whether it's a personal history, family history. Okay, so this is the recommendation, the article that we wrote in the American College of Radiology journal for breast cancer screening for women at higher than average risk. And these were updated recommendations we published in May 2023. I was one of the authors with Dr. Monticello, Dr. Newell, Moy, and Lee. So here we talk about who's at high risk. Women that have greater than 20% lifetime breast cancer annual risk. So they should start screening beginning at 30. Annual MRI beginning at 25 to 30. Women that have had chest wall radiation before age 30, annual screening at age 25 or 8 years after their treatment, whichever is later, and annual MRI ages 25 to 30. All women should be evaluated for breast cancer risk by age 25, especially if they're Black women or Ashkenazi Jewish descent women. Mutation carriers can delay their screening mammogram to 40 if they're doing annual screening MRI. Women diagnosed with breast cancer before 50 or with a personal history of breast cancer and dense breast tissue of any age should have annual MRI. Others with personal histories or those with atypia should strongly consider MRI screening. And women with dense breasts who desire supplemental screening, breast MRI is recommended. So these are our recommendations from 2023. And our previous recommendations, I have this table here, and we're doing kind of a little bit of a comparison between the two here. really there wasn't a lot of changes between the updated recommendations and our prior. We basically said that if you have a genetic mutation or you're untested first degree relative, you can delay your mammogram to 40 if you're doing annual MRI starting at a young age. But if you're not doing annual MRI, then recommendation is age 30. And you can see in the bold, we're considering abdominal radiation treatment that overlaps part of the breast also as a risk factor for chest or abdominal radiation at a young age. And for dense breast tissue, before we said consider annual MRI or ultrasound, but now we thought annual MRI is the best. But of course, if they cannot have MRI, then consider another contrast enhanced study like contrast enhanced mammography or ultrasound as an alternative. But the patient does have to understand benefits and risks by having ultrasound, which is a non-contrast study. And then we changed the risk assessment for all women, especially for Black women, minority women, Ashkenazi Jewish descent women, from 30 to 25. Those were the big changes. So, when we're doing personalized screening, we're trying to identify the women that we need to offer additional screening to. So those are the familial, and the hereditary. That's what we're looking for. That's what we want to capture. So lots of studies about breast MRI. Of course, we all know it's the higher sensitivity by doing MRI screening in the high 90s compared with mammography that may hit 59%. The false positive rate may be a little higher with MRI. Maybe you have a little bit of a lower specificity with MRI than mammography, but really the false positive rate is not a big reason to not offer MRI. And we know by offering annual screening MRI, we're finding early stage breast cancers and we're reducing interval cancers. And I have some of the articles on the bottom there, the references. This is a nice article by Dr. Janice Sung and her cohorts. They looked at breast cancers found at screening MRI, imaging, and mammography in women with at high risk. And what they found was that invasive cancers were more likely to be detected at MRI imaging, and most cancers detected at screening mammography were DCIS. And the interval cancers were found infrequently, but they were likely only to be found by MRI, and they were more likely, unfortunately, to be node positive and of the triple negative subtype. So this is kind of a nice, graph kind of showing us that with MRI as a screening test, we're more likely to get those invasive ductal cancers and the high tumor grades. So you have gene positive patients such as BRCA1 and BRCA2 mutation carriers. Screening MRI has very high sensitivity for finding of cancer, and it's also been shown to reduce the incidence of advanced stage breast cancers. So you can see, this is the National Cancer Institute. I pulled it right from their fact sheets. So you can see the mutation BRCA1, the percentages BRCA2, and then the normal patient that does not have a BRCA mutation at 12%. The study by Van Zelst is very interesting because it looked at annual mammogram. It was 2D. That's what they had to look at, full field digital, and MRI, and also biannual automated breast ultrasound in the BRCA1 and BRCA2 mutation carriers over a 2-year period. They found that mammogram and MRI was the highest sensitivity and the highest specificity. So if you're performing a mammogram and MRI in the BRCA1 or CA2 mutation carriers, and then we can extrapolate it to other mutation carriers, possibly like the PTEN, ATMs, all those other high, percentages of risk for breast cancer, then ultrasound really has not much of a role here. You're doing mammogram and MRI instead, or we should be, if we can. This is a 66-year-old. We have a genetics program and a genetic counselor, and we have a very busy risk clinic. So every patient that walks through the doors will get a risk assessment evaluation. We have computerized tools, and they plug in all the demographics and personal risk factors onto all the common lifetime breast cancer risk, and it gives us different percentages. Usually Tyrer-Cuzick, it will give us the highest percentage. So this patient was at 24.5 calculated lifetime breast cancer risk, and she wanted an MRI. She had her mammogram, and she came in for her MRI, and we see an enhancing mass in the right inferior breast. So there was no correlate on her digital breast tomosynthesis mammogram in the patient. She came in for a workup after the mass was found. We reviewed her mammogram that was done 6 months before. We repeated the tomosynthesis mammogram. There was nothing we saw, so we went to ultrasound, and she had a mass. You can see the small irregular mass at 6 o'clock in the right breast. We're able to biopsy this under ultrasound, and this was an invasive ductal carcinoma, nuclear grade 2. So this is not a low-grade DCIS. This is a nuclear grade 2 cancer, but we could not see it with the tomosynthesis. This is a young 36-year-old BRCA1, BRCA1 positive patient. She comes in for a screening MRI. I'm just showing you, just some of the images here. We're looking at this asymmetric non-mass enhancement that you're seeing in the left breast. This is a young patient. She has a lot of background activity in both breasts. And then I'm showing you just the MIP of this, and you see this diffuse non-mass enhancement on the left. We were able to just go straight to ultrasound with this young patient, and we found enlarged lymph nodes in the axilla. We biopsied one of the enlarged lymph nodes. You see that, we have this, the fatty hilum is, you see compressed. We have a big cortical thickening, and in the breast itself, let's see if I can find my pointer. There we go, my laser pointer. So it was curious, it was just like the whole breast had kind of heterogeneous hypoechoic and hyperechoic areas on ultrasound. So we just biopsied one of the multiple diffuse areas we saw. So both the breast, it was invasive lobular carcinoma, and the lymph node was metastatic lobular carcinoma. This is a 47-year-old. She comes in for a screening MRI, and she has a calculated lifetime breast cancer risk of 23.1%. She had genetic testing because she has a strong family history, was negative. So we see this small enhancing area on the right on the MRI, and then we have the mammogram next to it. You can see that we had to do an MRI biopsy in this patient. We could not identify the area on the tomosynthesis or ultrasound, and this was an infiltrating lobular carcinoma grade 1. So MRI is so sensitive, but also, highly specific. You have an area of enhancement in this high-risk patient, even if the mammogram and ultrasound did not reveal anything. We kept going, and we did an MRI guided biopsy. You see the clip there on the MLO view on the right, and this was a cancer. This is a 56-year-old. She's BRCA1 positive, and she comes in for her bilateral screening MRI. We have a small enhancing mass that we can see on the left. And we went to ultrasound in this patient, and you can see this irregular mass left 12 o'clock. And this was invasive ductal carcinoma grade 2. So personal history as a risk factor, the cancer detection rate with MRI is pretty high, 10 to 29 per 1,000 women with high sensitivities and specificities reported, many articles in the literature that have various high cancer detection rates. This is a review article by Manisha Bal. It's a very nice article. It was published in the Journal of Breast Imaging in 2022. She really reviews, she did a literature review of screening MRI for women that had a prior history of breast cancer. And these are women that we consider somewhere, they don't really fit in the, for our Tyre-Cuzick models. So they're considering the intermediate risk. So the cancer yield, when you look at the cancer detection rate for these patients, varies widely. 9.9, 18.1, 19.3. We're all over the map. But most of we're finding 8 to 20 cancers per 1,000 if you look at literature review. And these are, patients with their own personal history of breast cancer previously. So this is a 43-year-old. She does have a diagnosis of invasive ductal carcinoma. She's status post lumpectomy and radiation treatment. She's been treated. She's currently taking medication. She's on endocrine therapy and tamoxifen-like medication. And we see this small enhancing mass in the right inferior breast, very little. But she's a patient at high risk, young patient. And so we went to ultrasound, and, ultrasound can be quite powerful if you know exactly where to look after MRI lights up in an area. And we saw this very subtle hypoechoic mass, tiny mass, right breast lower outer quadrant. And we're able to biopsy this under ultrasound. And this was an ER positive, PR positive, HER2 negative invasive ductal carcinoma. This is another patient. She comes in for a screening MRI. She also has reasons to be coming in. So the patients have personal history or family history of breast cancer, and we see this mass enhancement. We also see some non-mass enhancement posteriorly in that right breast. So straight to targeted ultrasound, we're able to find this lesion, this hypoechoic area, which we were able to biopsy. And this was invasive ductal carcinoma and also ductal carcinoma in situ. So I wanted to show you that this enhancement that she has posterior to the mass, we could not see on ultrasound. So we did an MRI biopsy of the most posterior aspect of this linear enhancement. This was DCIS. So she had invasive and DCIS. So these women that are considered intermediate risk, we have some American Cancer Society previous recommendations. So we're not for MRI or against, because they said there's lack of evidence if really there's utility in this population. So these are the patients that are between 15 to 20% lifetime breast cancer risk. And they have a personal history of atypia, LCIS, ALH, ADH, dense breast tissue. So there are studies of this talk about MRI and how it performs in these populations, and it's actually done pretty well. And it detects early stage cancers in these patients with personal history of atypias. So patients that have the article by Ghon that I have on the bottom there, they had prior biopsies revealing lobular neoplasias and ADH, and they have a 10 to 20% risk of breast cancers, especially in women with LCIS. There's a 6 to 10-fold increased risk of invasive cancer at a follow-up of maybe as long as 17 years or later, and the risk can be bilateral, and most cancers occur more than 15 years down the line. But these women do hold a higher risk, so that is important for us to know. If you have a patient with ADH, the risk may be lower than if you have someone with LCIS. So you may have a 4 to 5-fold increased risk for invasive cancer at the mean follow-up of 17 years, and a 2.6 times increased risk of cancer 10 years after the diagnosis of ADH. So the risk is lower, but still measurable. Even patients with ADH do have a higher risk for breast cancer. So looking at this nice article, the review article by Dr. Ball in JBI, she also talks about women with lobular neoplasia and ADH. And when you look at the literature, the cancer detection rate is very reasonable per 1,000 MRI exams in these patients with lobular neoplasia or ADH, so it cannot be ignored. So women that have lobular neoplasia or ADH, the single institution, most of the analysis have been retrospective, single institution, they're showing cancer detection rates from 11 to 16 cancers per 1,000 MRI exams. And women with lobular carcinoma in situ will benefit more than the women with atypical lobular hyperplasia or ADH, Dr. Ball summarized from her literature review. This 51-year-old comes in for screening. She has a personal history of left atypical lobular hyperplasia, of radial scar, previously excised, and she has heterogeneously dense tissue. So she qualified for this MRI exam. And I'm showing you here this mass enhancement on the left. And we went to her mammogram. She has a busy pattern. She's had prior surgical excisions. She has lots of calcifications everywhere. And she has the surgical scars, but we thought we could see some subtle architectural distortion within the left breast upper quadrant. We went to ultrasound in this area. We saw kind of this hypoechoic, heterogeneous area. Of course, some of this is pretty subtle, and really you see this on real-time imaging. But we were able to biopsy this, and we did get invasive ductal carcinoma and DCIS. So if we hadn't found this on ultrasound, if we weren't convinced we could see something on the mammogram, this patient would have had an MRI biopsy of this area. All right, this is a 61-year-old, and she also comes in for her MRI, and we have a personal history in this patient. So you're seeing two masses. You're seeing that enhance on MRI in this patient, possibly a third one. On the mammogram, we're seeing some asymmetry on the tomosynthesis on one view in the back of the breast. It wasn't as, it wasn't as well identified as we could see on MRI. On MRI, we saw multiple findings. So we went to ultrasound. And in this patient in close proximity, right 9 o'clock, we have an irregular hypoechoic mass. You see echogenic rind, partially visible in ultrasound. And then at right 8:30, similar looking mass, irregular with the partial echogenic rind visible. So we're able to biopsy these areas under ultrasound. And they were both invasive ductal carcinoma, nuclear grade 2. What about women with dense breasts? We have found, looking at the literature, that if you have heterogeneously dense or extremely dense breast tissue, you may have a 1.5 to 4-fold increased relative risk for breast cancer compared with a patient with scattered fibroglandular tissue or fatty breast tissue. So having dense breasts does confer you in some inherent risk, and masking risk also. I may miss your cancer, and there is some inherent relative risk for you. So if you have this article here, this review, looking at women with that dense breast and screening MRI, and we're seeing many patients, different numbers of MRI examinations, but overall the cancer detection rate is quite, formidable here. Comstock 15.2, Baker 16.5. So we're and even in the follow-up of the dense trial, second round by Vinhausen, 5.8 cancers per 1,000 in women that have dense breast tissue. What about women that have different elevated breast cancer risks and MRI? Well, when we're looking at women with different risks, like we have the BRCA mutation carriers, chest wall radiation, family history of breast cancer, personal history of breast cancer, high-risk lesions. SIPO had 5170 screening exams in over 2,600 some women. They found 67 cancers in these different types of carriers of risk level. What they found was, obviously, the most cancers detected were in the BRCA and the radiation treatment to the chest wall patients, as you can see here. But personal history did better than family history of breast cancer. And actually the high-risk lesions, there were a lot of cancers that were found by doing MRI in high-risk lesion patients. So really, when we're thinking about women that are at risk, we really ought to consider, Dr. Sippo thought, the women that have personal history of breast cancer and also the high-risk lesions. What is the cost effectiveness of doing screening in these different risk, percentages of women? Well, they did an analysis and a simulation with the data from the DENSE trial, and Kaiser determined that screening MRI and mammography every other year can be considered cost effective for women with dense breasts. And really, the incremental cost effectiveness ratio was about 8,800 per quality adjusted life year. And everyone thought that this was okay. People were willing to pay that type of threshold. Dense Trial Study Group reported the MRI screening is cost effective if performed in women with extremely dense breasts every 4 years. Tollens looked at modeling data, including the results from the Comstock trial, the EA1141 trial, to see if it was cost effective in women with dense breasts when compared with tomosynthesis. And they felt it was cost effective if the MRI exam was $593 or less. So unfortunately, we have this great modality that can be quite expensive. So people are doing all this data analysis to see if can we afford it as a country, as a nation, globally. Can the patient afford it? So looking at screening utilization overall, was 11-year study, and they went from 2007 to 2017. It was published by Lee in the Journal of Breast Imaging in 2021. And they found that 55% increase in screening breast MRI utilization every year from 2007, pretty much. More patients got to MRI. However, it's estimated that 9% of women in the United States are eligible for high-risk breast MRI, and only a very, very small percentage of those actually get to the MRI exam. So the compliance is still really falls short of optimal. So where are new directions? Well, abbreviated MRI, the shortened breast MRI protocols, we get the one pre-contrast T1 weighted image, and then the first post-contrast T1 weighted image, subtraction, MIP. The exam time is going to be 10 minutes or less versus the 30 minutes, right, for the full protocol. And the clinical indications and applications are supplemental screening for women with dense breasts, intermediate risk women that don't meet the criteria for annual screening MRI, the full protocol, high risk women when access to full MRI is limited, and also problem solving for select clinical scenarios. So abbreviated MRI has advantages. The studies so far show that the cancer detection has been shown to be comparable to full protocol. There's higher sensitivity when we use breast MRI compared with mammography and ultrasound. The shorter scan time and interpretation time is so much shorter for the doctor, for the patient. So you have, patients are more compliant. It's better for the patient, it's more convenient, it's more comfortable. And usually, we expect if patient has to pay out of pocket, lower costs, greater accessibility, we can schedule more patients on the magnet, because it takes 10 minutes or less as opposed to the 30, so we can put more patients through. So looking at the Dr. Comstock trial, the EA1141 trial, they did abbreviated MRI in women with dense breasts undergoing screening, and they compared it to tomosynthesis. It was cross-sectional, private practices in the United States and Germany, and they looked at these patients over time at academic and community hospitals and also private practices. They found in these average risk women, 40 to 75-year-old, that had heterogeneously dense or extremely dense breasts, all women had both tomosynthesis and abbreviated MRI, and each study was randomized and read independently. And MRI, when you compared it to tomosynthesis, found a lot more invasive breast cancers. And the reduced specificity was really not significantly different from that of tomo. And they found that the results really demonstrate abbreviated MRI improved breast cancer detection for these women with dense breasts, and they were of average risk. They did not have a strong family history or personal history or genetic mutation. And there were no interval cancers during the observation period. Now, looking at the dense trial that we mentioned a little bit by Baker, and this is dense tissue and early breast neoplasm screening. It was a randomized controlled trial to look at the effect of supplemental MRI on interval cancers in women with extremely dense breasts. This is the first study that actually shows us that MRI is reducing mortality, because we found for the women that had the MRI invited group, 2.5 cancers per 1,000 versus the mammography only group was 5.0 per 1,000. So we're able to reduce interval cancers by 50%. And the incremental cancer detection exceeded 16 cancers per 1,000 by doing MRI. So much lower interval cancer rate and much higher cancer detection rate. So you can't argue with all these studies that have shown us we're finding more cancers. But where do we go from here? High cost, limited accessibility. Many radiologists that do breast imaging don't have access to breast MRI, don't have it within their practice or their department, or have to share it with, the rest of radiology. So that poses challenges for us. So abbreviated MRI may help mitigate some of these barriers. Of course, we have to do more research on screening MRI for women at intermediate risk, and multi-center prospective studies are needed. And we have to look at our outcomes in breast cancer-related mortality. So, summary. The recommendations for use of screening MRI are evolving based on new clinical evidence. MRI in those at high risk, it's clear evidence to support screening. For the women at intermediate risk, we continue to investigate these women with dense breasts, with atypias, personal history. There's mounting evidence of value in these populations. And there may be a role for abbreviated breast MRI, for widespread adoption of MRI for screening purposes, especially for the intermediate risk women. All right, so now we're done with that talk. So true or false, is MRI recommended by the ACR as a supplemental screening tool over ultrasound for patients with dense breast tissue? Yes, it is. Yes, we took away the ultrasound recommendation side by MRI. Of course, we realize many patients continue to have ultrasound, but they have to understand the risk versus benefit ratio. Lots of false alarms, lots of benign biopsies, lots of short-term follow-ups with ultrasound. So MRI is the supplemental screening tool of choice. And then the second multiple choice, what's the best screening combination for patients at high risk? Remember some of the studies, Wenzel's at the BRCA1, BRCA2 population. Out of all these possible choices, and they're good. If you don't have anything else, you got to do full field digital and ultrasound, or tomo and ultrasound, or MBI and full field digital. But the best screening combination, MRI and full field digital mammography, choice D. All right, my references and my email. So you guys can send me questions if you think of more things afterwards.
I'm sure you got a lot of emails after those interesting lectures.
That's fine. Send them. I love to hear from you guys.
Thank you so much. That was amazing.
All right, I'm giving you a chance to write down my email. I'm going to stop sharing. Okay.
Can we have a photo? Can everyone open cameras?
I wore my colorful scarf just for the photo.
Oh.
Okay. Dr. Asha, Dr. Amal.
I can't open now, Merit, because I stick something on the camera and I removed it at the beginning and then I resticked it.
You're like, Rasha, I can hear you, but I can't see you.
Yes, I stick something on the camera because I have a lot of Zoom meetings and not every time I wear my veil. And sometimes the camera just opens incidentally.
I understand completely.
Yes, I have protection on the camera now.
Oh, very good, very good. I got it. So, you have to send me the photo.
Yeah.
Did we get a photo, Mary?
The photo or not yet?
No,
okay, so if you guys have a screen capture, send it to me.
Okay, 1, 2, 3. Okay, got it.
All right, perfect.
Okay, so up to questions. So less MRI fans. I thought MRI would get more questions than the tomo. So Dr. Manar Lesawi has a very smart observation here. Interesting question. When do you recommend stopping MRI screening? She noted that in the presentation, some of the cases were at the pretty age of 50 and some are at the pretty age of 70, were undergoing annual MRI screening. So her question is, could you clarify the age or criteria at which you would discontinue MRI surveillance?
So, for most of our patients, usually if they are high risk, we discuss 65 to 70 as a stopping point. And we have some patients that continue to insist coming in they look better than me. So, I'm like, God bless you. Okay. So like, I am having it. My doctor recommended it. Here is my script from my doctor, and my insurance is covering it. Okay. So I'll do it. And then, of course, I find cancers in these very lovely 70-year-olds, and it slows them down very little to have an outpatient surgical procedure, and they choose radiation or tamoxifen, and they go on about their lives, and they usually are running circles around me. So I'm like, yes, all for it. Obviously, we typically, though, for most patients, for surveillance, we do say 65 to 70. Now, if a patient is in poor health and they're a lot younger than 65 to 70, obviously they're not a good candidate for MRI. The position is uncomfortable for them. They may have multiple other comorbidities that prevent them from having the MRI. So even in younger patients that are in poor health, renal disease, other issues, obviously they're not going to get it. But if you're in good health and you insist on it, I'm not going to stop you. If you're, honestly though, I am not doing screening in 80-year-olds, or, there's just no reason for that. By the time we're 80, most of us, our breast tissue is quite nicely less dense, and tomosynthesis is doing a good job, and ultrasound does a good job. And, so I do talk to them about that. I discuss about after menopause, in most of us, our breast tissue is less dense, tomosynthesis becomes even more sensitive, your ultrasound. And so we have a good discussion about it.
It would be kind of individualized then. With
yes.
Sounds good. That's all from my part.
Okay.
Can I speak honestly about the challenge to conduct good MRI screening in our region? First, radiologists think about this background parenchymal enhancement, a lot of numerous foci in this young lady, and the radiologist is the one who will stuck in reporting, which is suspicious, which is background, and usually we don't have comparison studies.
Right.
If we convince the patient to do it once, we will not be able to convince her again. Then, even after we find some suspicious findings, here comes the second challenge, that we don't have MRI biopsy in our region that much. I think a few centers in the Gulf area, and I'm not sure about also in Egypt, not that much at all.
I think it's very challenging.
Yes.
I think,
so again,
I think if you don't have MRI biopsy capability, I think it becomes very difficult and stressful for a breast radiologist to do breast MRI well.
Yeah.
No,
So
because
this is why breast MRI screening is not that popular in our region.
And that makes sense to me. And the thing, so when we started doing breast MRI, we realized that we have to be able to do MRI biopsy. So very quickly, we spoke with any vendor that could help us with any MRI, compatible device, which was a hand device at that point, but it was, and you had to take the needle in and out. It was cumbersome, but we knew that if you're going to practice MRI and you're doing screening surveillance with MRI, you have to be able to biopsy these under MRI. You're not going to find them on tomo or ultrasound. And, so we have a lot of patients that come to us because something was found in outside MRI. They did a 6-month follow-up. The patient doesn't want to go back there. They don't want to have another MRI. I mean, there's a lot of issues, and I understand that completely. So, but I think background enhancement can be problematic. In most young people, it's bilateral. You have to get comfortable with what to let go and what to call back. And then once you call it back, you have to be able to do a biopsy, because like you said, patients are not going to come back for a 6-month follow-up. And so I think those are challenges. So I think you have to work within the challenges in your environment. So if contrast enhanced mammography makes more sense,
Yes, I was just
Yeah,
going to
yeah,
tell you,
this
we
is
There
have
the
is
time.
nothing wrong with
contrast-guided
contrast
biopsy.
enhanced mammography. And the next time you invite me, we'll talk about contrast. I love
Yes.
contrast enhanced mammography.
You know where I'm heading to? I was heading toward using the contrast, and I was
Yes, I
asking
love
Dr.
it.
Rasha
I
to.
love it. We have patients that don't qualify for MRI, refuse to lay on their stomach. They have metal, they're claustrophobic. I mean, you can understand. We all get claustrophobic in there, so you understand. And we have reduced our protocol as much as we can reduce it. We have not abbreviated down to the 4 minutes yet. My partners are like, no, not that sequence. I need it. And then everybody's fighting. I need that one. I need my fat sequence. I need this. I need that. So we cannot get it down past, we have it down to like 17 minutes, 16 and a half. That's about it. On a good day, if I could convince them to reduce a few more sequences, I will get it down to 12 minutes. But anyway, but we like contrast. Contrast is helpful. So
yes, and it's available, the biopsy, contrast-guided biopsy, it's available in Egypt. But the MRI, no.
So with contrast, if you're doing tomo and you have the upright, you easily can transition to a contrast enhanced, biopsy. If you have the tomo capability, tomo biopsy. So I think that's a more doable thing.
Yes, nice.
So a couple of more.
Is there studies that address the screening with contrast enhanced mammography in young population in like 30 or 20?
It's more irradiation, Merit.
Yeah, I think the radiation is a concern, not the contrast so much. It's the radiation.
Yes, so again, these are the population which we can't offer MRI without having MRI biopsy, and they have the background parenchymal enhancement. So
We're having
this
more
again.
questions coming in.
Yes.
Is there a time for more questions? A couple more questions.
So let me just address this for a minute, Merritt. I think with the background enhancement, once you convince the patient to come back, you will feel a lot better that it's similar, symmetric, stable, and you don't have to react to it. As you can let it go. I do think in the population in their 20s, doing contrast enhanced mammography is a concern because of the radiation. Because we don't do mammograms in those young women. We try, to avoid as much as we can. So I do think you're a little bit stuck there. Yeah, I agree.
Okay, so last scenario. Can we do MRI screening for these young 20s high-risk group? And then if we really find something suspicious, we can do the contrast enhanced mammography to target it biopsy.
Yes, of course you can. Of course you can.
Okay, so at least we find
Of course you can. I mean, one contrast enhanced study is not going to hurt the patient. I don't want to do it every 6 months.
Double exam. It will be a double exam because you have to do the contrast first, because you have to target the lesion. You should know its place on the contrast. So this means you will do 2 contrast mammographies.
Right. Yes.
One
you'll
for
do
the biopsy and one for the contrast itself.
Yes. Yes. You may find a cancer, Rasha. You may find a cancer.
Yes, well, if it's very, if it's very suspicious, then we have to do this. Yes.
Right.
The incidence that we do not find something that we have seen in MRI after a second look ultrasound, I think it's to be malignant. It's a very low incidence, I think. And we usually do a second look ultrasound. We find the lesion which was missed from the mammography, from the initial mammography and the ultrasound.
No, I think you're right. But the studies, Rasha, show that even in the cases that are not identifiable on ultrasound, although the percentage of breast cancer is less, it's still not negligible. So if you don't find something in ultrasound, you still have to pursue it, because it's not the percent the percentage is not less than 2%. So it's not zero. So you still have to pursue it. You know, we did some work on this with targeted ultrasound. Significant percentage of the cases we couldn't find with ultrasound still were malignancy. I think Wendy DiMartini wrote something too. I mean, a lot of authors have written on this, but it's not as high. Definitely, if you find an ultrasound equivalent, the chances of malignancy are much higher. But even if you don't find it, and you know what aren't we going to find? We're not going to find the non-mass enhancement, right? Those are tough. Those are tough to find with ultrasound. Even if we have the new criteria now by Dr. Leong in the BI-RADS ultrasound for, you know, they're still tough. I'm like, am I looking at heterogeneous breast tissue, or is this really what I'm looking at? So those are tough. The non-mass is tough. So I think you're right. You have to double dose them because you have to give the contrast, you have to find, and then you have to bring them back and do the biopsy.
Okay. A couple of
But it's okay. If we can't do it with MRI, then we have to do it with something else.
Yes.
A couple of more questions. So one question here from Beatrice about kinetics. I used to say morphology trumps kinetics, but I'm not using the word trump anymore. So I'm leaving this question to you. Do you use the intensity curves when deciding on the lesion characteristics?
So morphology is very important. So I think, yeah, I'm using the kinetics also, but I'm still happy with morphology trumps kinetics. Yeah, you know, because so morphology is so important, but kinetics are important too. So we have to look at those too, because sometimes it steers us like, you're on the fence, you know, and you're like, I'm doing it. You pull the plug, you're bringing her back because, you know, the kinetics are important too. And it can work the other way. But morphology is so important.
Another question, which risk assessment tool model do you prefer to predict cancer risk? From Dr. Mohammed Yahya.
Okay, so which risk assessment model?
Tool model do you put to predict the cancer risk? So the risk assessment models.
So for the risk assessment models, we have what's called CRA. It's a computer platform that allows to pull all the demographics of the patient and their own history, and it gets plugged into all the risks. So GALE, Klaus, Boudicca, Tyrer-Cuzick. So it populates all the risk assessment models. Typically, Tyrer-Cuzick is the highest. In most cases, because it takes second-degree relatives. It really does look at morphometrics. It looks at prior biopsies. It looks at hormone use, so many other things. So typically Tyrer-Cuzick is going to be the one, but sometimes we use GALE. Sometimes, you know, whichever model gets that patient over 20%, I'm going to use it and offer that additional supplemental screening to them.
Okay, so it basically populates everything, and then you look at if it's over.
That's
20,
right. We look at it. Yep, exactly.
Exactly. Okay, excellent. So another question: which alternative imaging modality can you use as supplemental screening for high-risk group if MRI was contraindicated? I had already answered that CEM, but I'm
CEM. Yeah. Contrast enhance. Yes, contrast enhance.
Okay, and there was a question before that mentioning MR biopsy. The question was, what instruments do you use for MRI guided biopsies? And the question was regarding equipment. Okay,
so we use Suros, which is Hologic, and you know we use the Holter system, the console, and then the biopsy device are MRI compatible.
Excellent.
And we've used that all along since they developed it. Before that, we were using a handheld device that was MRI compatible back in the early 2000s. But since Hologic came through with their biopsy, we've been using that and we've been very comfortable with it.
Another follow-up question from if morphology is benign on MRI, is this indicated for biopsy even if it is not identified on mammo or ultrasound?
if the morphology is benign on
Yes.
MRI
Yes.
and
So
the mammogram and ultrasound are,
there is no occult on mammo and ultrasound.
so what are we, we're looking at something that we're going to give this a BI-RADS 3. It has benign morphology.
Right.
So you can't find a mammogram or ultrasound. Yeah. So
Yes.
you're going to do a follow-up.
Follow up
Okay.
with MRI.
Yeah.
Even if newly developed,
So
I think it has many factors. The age.
there's many nuances here. So on a baseline, you don't know if it's newly developed or it's been there for 10 years. In those cases, if the mammogram and ultrasound and the morphology looks benign, the kinetics are not scary, then you're going to do some kind of follow-up. Whatever follow-up in your protocols there are, 6 months, a year, whatever it is that you're able to do in your area.
Yes.
If it's a newly diagnosed breast cancer patient and you think it's a probably benign finding because the morphology looks benign, you can give it a probably benign, but I would biopsy it in the face of a newly diagnosed breast cancer patient. And you give it a recommendation in your report that this has likely benign characteristics, but the patient is undergoing, diagnosis, treatment for newly diagnosed breast cancer, and we're going to biopsy this to prove it's benign. If it's a patient that never had this before and has been having an MRI every year and it's newly developed, I would look at that carefully, very carefully. And I would look at the patient's age, family history, personal history, and everything before I decide to let it go. There are certain cases, though, that a 6-month follow-up is reasonable. And there are certain cases that you're going to go ahead and biopsy something that's newly developed. I think like Rasha said, right? Rasha.
Yes, yes, it was me. Yes,
it was you. Yeah, that's what I thought. I thought it was you. So we have to look at everything on the patient, including what brought her to this supplemental exam. And then you make a decision based on that. But on a baseline, morphology benign, reasonable to do a follow-up. Newly diagnosed breast cancer patient, I probably biopsy it just to put that out of the patient's mind, relieve anxiety. They don't need to worry about yet another thing you're following in the face of a new diagnosis. And in a postmenopausal patient, like my 72-year-old that may come in for a supplemental screening, you find something new, we better be careful with that too, because we do know that there are some malignancies that may look relatively benign.
Yeah.
Sounds good.
Okay.
Yes, I think enough. We have overloaded.
Well, I think there's lots of nuances, like Rasha said. Absolutely.
Yes. We have overloaded you, with questions.
Oh, listen, it was a pleasure. It was a pleasure to be with you this afternoon.
It was our pleasure to have you, actually. Yes.
Yeah, so it was a pleasure, and it's so nice because I have so many friends in this group. I am very honored and,
Yes.
very happy to be with you.
Thank you so much. That was amazing.
Yeah,
On
so
behalf of
next
all
time
the-
we'll see you face to face.
Yes, I hope so. Yes.
Yes,
Yeah, I think RSNA, right?
that's right. RSNA.
Yeah.
And
But who's going to RSNA?
I'm going.
Yeah, you should go. But
I'm there all week. I'm there all week. I have meetings all week. So I'm there. Yeah. But, well, whoever comes, please come and find me and say hello to me. Come and find me.
Okay.
Okay?
Thank you so much for.
All right. Thank you, guys. It was a pleasure. Thank you.
On
Thank you.
behalf of
was
all
our
the
pleasure.
EGSBI board members and everyone here, thank you so much. We are so happy with this webinar, and it was an excellent topics, and it was very practical,
Good
very
questions.
helpful, good question,
Thank you
good
so much.
discussion.
Thank you,
really,
guys.
really appreciate your time, your expertise that you shared today. Thank you
Thank
so
you.
much on behalf of
Thank you,
all the
guys.
Addicts Association
Thank you.
President.
Have a nice
Have a
evening.
nice evening.
You too.
Thank
Bye.
you. Talk to you soon, guys. Talk to you soon.
Okay.
Bye.
Take care.
Thank you, Heba. Thank you, Dr. Asha. Thank you, everyone.